Good evening, everyone, and happy Friday. Welcome to our October Facebook Live program. And tonight, I'm really excited to welcome Dr. Jennifer Villasenor-Park, who's the Assistant Professor of Clinical Dermatology at the University of Pennsylvania, right around the corner from me, actually. And it's really exciting to have you with us. And tonight, we're going to talk all about lymphomatoid papulosis, or LYP. Welcome, Dr. Park.
Thank you, Susan, for that kind introduction, and thank you everyone for joining us on a Friday night to talk about lymphomatoid papulosis. I appreciate the invitation to speak to you tonight.
That's really great. I'm so excited to be able to spend a whole program just on this topic. I know we get many questions from folks who have LYP. Some people have LYP and mycosis fungoides, so hopefully we'll talk a little bit about that too. And I'm sure there will be a lot of questions. So I'm going to turn it over to Dr. Park, and she's going to take us through a nice presentation, but at the same time, write down your questions and put them into the chat. And once we're finished with the presentation, we'll open it up for questions and do some open Q&A. So we'll go ahead and get started and dive right in.
All right, thank you, Susan. So as Susan said, I'll be talking to you tonight about lymphomatoid papulosis. And I don't have any relevant disclosures for this presentation, so no conflict of interest. So this is the group that I feel very fortunate to practice with. This is our Penn cutaneous lymphoma group. Dr. Rook, as you can see here, he's been the director of the group for over 30 years, and he's been a wonderful leader and really pushed the field farther. And Dr. Kim, I think she's also given a Facebook Live presentation in the past, and she's been with the group for at least 15 years. And these are my other colleagues who are also wonderful. So feel privileged to be able to practice with them and to also take care of patients like you. So this is an outline of what we'll be discussing tonight. So I'll give you a brief overview and introduction about lymphomatoid papulosis. We'll talk about the prognosis of lymphomatoid papulosis and its associations to other lymphoproliferative disorders, as Susan mentioned or alluded to, the association with mycosis fungoides in particular. We'll talk about the general or classic clinical presentations of LYP, how it's diagnosed, and then we'll also go through treatment. So lymphomatoid papulosis is part of a group of disorders that are termed CD30 positive lymphoproliferative disorders. So that's a mouthful, but it's a general distinction for this group of disorders. So pictured here is a class presentation of papulosis, papules and nodules on the trunk and extremities. And within this group of disorders, lymphomatoid papulosis is one, and anaplastic large cell lymphoma is also part of this group of disorders, and that's pictured here. And there are cases that we've termed borderline or indeterminate cases where we really have difficulty distinguishing between the two of these disorders. So what exactly does CD30, what does that mean? So I thought I'd present to you a very, very simplistic view of what CD30 means and give you a very simplistic view of the immune system. So as you know, the immune system has very, very many different cells. The most common types are T cells, which are depicted here, which can be either CD4 positive or CD8 positive. We have B cells and NK cells that are also part of the immune system. And the job of your immune system is to be able to distinguish and get rid of foreign entities like bacteria and viruses. And so CD30 is a cell surface protein. So it's a protein that's expressed on the surface of these cells, and typically when they're activated. So CD30 is on the surface of these cells, and when they bind the ligand, or its ligand, CD30 ligand, this is present on B cells, T cells, eosinophils, and macrophages, which are other cells in the immune system. Signals occur within these cells that then help modulate the decision to undergo cell death or cell survival. So very simplistic view, but just to give you an overview of what CD30 really means. And so CD30 is really mainly a histological distinction, meaning CD30 was used as a way to really classify these disorders. And so when you have a skin disorder and require a skin biopsy, typically this is what the pathologist looks at when your dermatologist takes a piece of your skin. And so the tissue is processed and dyed, colored in certain ways. And this is really what the pathologist sees in all types of skin biopsies. So he or she sees a cross section of a piece of skin, and you can see the top layers of the skin here. And these darker colored areas are the cells in your skin. So each of these biopsies can have a specific pattern of inflammation of cells. So the way that these cells are arranged in the skin clues in the dermatopathologist as to what particular diagnosis they're dealing with. And each individual disorder has very specific findings. And so they can further stain this skin biopsy to look for cell surface proteins like CD30. And this is what's depicted here. So that kind of gives you an idea as to what that means. So CD30 positive lymphoproliferative disorders, it's actually the second most common cutaneous lymphoma, second only to mycosis fungoides. And because CD30 positivity can be seen in a variety of things, it can be, you can stain for CD30 and look under the microscope and see it in things like eczema, bug bite reactions. It can be seen, of course, in lymphomatoid papulosis. It can also be seen in other lymphoproliferative disorders like mycosis fungoides. So it's very important to take both the clinical presentation as well as the biopsy findings in order to make the diagnosis, because CD30 positivity and the finding under the microscope can represent a number of disorders. So lymphomatoid papulosis, as we know, is a a recurrent self-healing grouped or scattered papulonodular eruption of the skin. As I alluded to earlier, it is a CD30 positive lymphoproliferative disorder, and it is the most common type, but it is overall very rare. So it's estimated to, the incidence is about 1.2 to 1.9 cases per million persons in the United States. There's a predilection for men versus women, and it can occur at any age. So there are pediatric cases of patients with lymphomatoid papulosis, but the average age of onset is anywhere between 35 and 45 years, with a peak at the 5th decade. There are many different hypotheses as to why lymphomatoid papulosis occurs in some people versus others, but really the cause is unknown. There are some genetic mutations that have been identified and reported, but as to the clinical significance of these mutations, it's really not clear. So in terms of prognosis and associated malignancies, the survival estimation, 5-year survival, is actually very, very good. It's close to 100%. So there's a controversy in terms of regarding lymphomatoid papulosis as a benign versus malignant disorder, because the survival is very, very good. That being said, there is a relatively high risk of secondary malignancies, and there are various estimations. So anywhere between 5 and 30%, some have estimated 40 to 60%. And most of these malignancies include mycosis fungoides, anaplastic large cell lymphoma, typically the primary cutaneous type, or Hodgkins disease. So oftentimes these secondary malignancies, in terms of mycosis fungoides, it's typically early stage. So patients tend to present with stage 1A or 1B. And the interesting thing is that most patients with lymphomatoid papulosis and mycosis fungoides, the prognosis with regards to their mycosis fungoides is better than compared to others. So less common associations, less than 10%, include different types of leukemia, AML, CML. B-cell lymphoma has also been reported, myelodysplastic syndrome, and multiple myeloma. But these are very uncommon secondary malignancies. So risk factors for these secondary malignancies: male sex, older age, and there are specific types or subtypes histologically of LyP that I'll discuss in a brief second. So the clinical presentation of lymphomatoid papulosis, so this is the classical presentation. They, again, typically occur in groups or crops, and they can present in different stages of healing. There's a size distinction between lymphomatoid papulosis and other disorders, particularly primary cutaneous ALCL or anaplastic large cell lymphoma. So in lymphomatoid papulosis, that they're usually less than 2 centimeters in size. So about half of patients are asymptomatic, but the other half can have either severe pruritus or itching. Sometimes they can have pain associated with the necrotic lesions. And most of the time, it can take weeks to months to heal completely. And they often heal at different stages and different times. Sometimes they can leave darker spots or lighter spots or hypopigmented spots. Some patients can also have scarring, particularly the types that involve the blood vessels and have necrosis. But the general rule and the general feature for lymphomatoid papulosis is that they always self-resolve and go away. So, so these are some pictures. I'm showing you some of the presentations. So some patients can have very few lesions affecting their skin. Some can have hundreds affecting their trunk, their extremities, which are the most common areas of involvement. And then sometimes they can heal with this central crust or necrotic or eschar. And again, it's more common in types of lymphomatoid papulosis that involve blood vessels, but it can occur in other types as well. So as I alluded to earlier, because the histological features can be similar to other disorders, it's very important to take in both the clinical features as well as the histological features. Because under the microscope, lymphomatoid papulosis can look like this or this if you biopsy any of these lesions. And these, the 3 entities, lymphomatoid papulosis, and this is, these are common clinical presentations of primary cutaneous anaplastic large cell lymphoma. And then on the right over here is mycosis fungoides with CD30 positive large cell transformation. So under the microscope, all 3 of these entities look almost identical. And oftentimes, dermatologists as a diagnosis will get the diagnosis from the pathologist as CD30 positive lymphoproliferative disorders. It'll be very rare that an actual line diagnosis of lymphomatoid papulosis will occur because it's very hard to exclude those entities without seeing the patient. So again, it's very important to have a dermatologist who has seen diseases like this, and to have a pathologist who's trained at looking at these types of diseases. So pathology. So this, what does lymphomatoid papulosis look like? I showed you a picture earlier of what it looks like under the microscope, but this is a table of all the different types histologically or under the microscope that lymphomatoid papulosis can look like. So the WHO, the World Health Organization, has identified at least 6 subtypes, and there are actually a couple more that are not listed here that are well described in the literature. But again, type A, so again, there are at least 6. Type A is the most common type. And the reason why I mention these subtypes, is because under the microscope, they can mimic things like mycosis fungoides. So type B can look like mycosis fungoides. So it's very important to look at clinically what the rash looks like. And then type C can look like anaplastic large cell lymphoma. Type D can look like an aggressive form of cutaneous lymphoma, so CD8 epidermotropic aggressive T-cell lymphoma. So again, it's very important to take into context clinical presentation. So the other reason why I'm showing this to you is because type B and C are much more commonly associated with malignancies. The other thing to note is that even though there are many different types of LyP disorders that appear under the microscope, it's really not clear whether one subtype is more, more aggressive or more extensive than others. So the clinical significance of these subtypes is not really known. But we do know that types B and C are more commonly associated with other malignancies that we discussed earlier. Typically, they're more CD4 positive, which is only important in regards to how treatment is chosen. So with the exception of types D and E, which tend to be CD8 positive, and then LyP in children tends to be CD8 positive. Another interesting point is that one patient can actually present with different histologic subtypes in one patient. So, so moving on to diagnosis and staging. So again, it's very important for the clinician to take a very thorough history and be very familiar with the clinical presentation of lymphomatoid papulosis. So if you have any B symptoms, so B symptoms are a very common presentation of patients who have lymph node involvement for a variety of entities. Not lymphomatoid papulosis specifically, but if you have any weight loss, any unexplained weight loss, drenching night sweats, fatigue, those are symptoms that you should tell your doctor. If you've had any history of immunosuppression like HIV positivity, or taking medications that would suppress your immune system, the doctor that you see should also take into consideration the nature of how your rash looks, the size, whether it's self-healing. Do you have other lesions like patches that could make the diagnosis lean towards more of mycosis fungoides? You should get a very thorough lymph node examination to determine if there are any abnormal lymph nodes or abnormal spleen or liver. Of course, the biopsy of your skin will show the findings of a CD30 positive lymphoproliferative disorder. In terms of lab testing, it's very uncommon for patients with lymphomatoid papulosis to have any significant abnormalities, except in the case of patients who might have a secondary lymphoproliferative disorder. So this is why we check for these things. We also check for HTLV1 and 2 to rule out patients who live in areas that are endemic with this type of virus, because adult T-cell leukemia or lymphoma can sometimes be mistaken for other things. And typically, radiology studies like CT scans, X-rays are not done because involvement outside of the skin is extremely rare, and only in patients who have atypical findings on exam, like any palpable lymph nodes or B symptoms, abnormal labs, would we really consider that. Lymph node or regional lymph node involvement in LYP is extremely rare. And bone marrow biopsies are typically not done for LYP. So in terms of treatment, the decision for treatment really depends on you and your symptoms and the extent of your disease. So is it itchy? Is it involving a large proportion of your body? Certain treatments require you to travel to centers that offer these treatments. So whether these centers are convenient to you is also a consideration. Whether you have any other associated symptoms. Do you have other diseases that would preclude you or be a little more risky if we were to give you certain medications? For example, methotrexate is a very common treatment for patients who have extensive disease, but if you have an associated liver disease, then it might not be best fit for you. And then unfortunately, insurance sometimes dictates how we go through or what we start with in terms of treatment. So in terms of treatment, so we typically try to divide treatment as skin-directed versus oral systemic treatment. And this, the types of treatments that we offer for patients or have found that have been effective for patients with lymphomatoid papulosis is very similar to treatment for patients with mycosis fungoides. Because lymphomatoid papulosis has an excellent prognosis, patients who have very few lesions or are asymptomatic or not bothered by them, observation is a perfectly reasonable choice. Topical steroids can also be used, but it's not a preventative in terms of preventing new lesions. It can certainly help with symptoms, and it can help resolve lesions faster, but very, very few CR. Phototherapy is a very common treatment and very effective treatment. The one thing I should preface all of this with in terms of treatment and efficacy in lymphomatoid papulosis is that there are very, very few large studies, as in many of the studies with mycosis fungoides and treatment. So it's most of the studies evaluating the efficacy of treatment for patients with lymphomatoid papulosis or even mycosis fungoides are small. So that's something to keep in mind. But phototherapy has been reported to be very useful, particularly PUVA. And then narrowband UVB can also be helpful. Unfortunately, once patients stop treatment, recurrence is very common. And in some cases, some clinicians will institute a maintenance regimen with phototherapy, meaning you are slowly weaned down off of phototherapy. But there really is not a lot of evidence regarding what the best protocol or what the best way is to undergo maintenance treatments. So there's really no standard way to do this. And then the other thing is that once you decrease the frequency with which you undergo phototherapy, particularly narrowband UVB, it becomes that much harder in terms of decreasing some of the associated risks like phototoxicity. And then with things like PUVA, you also have to balance the risk of melanoma and non-melanoma skin cancers, which is associated with a large number of treatment sessions. So those are things to keep in mind. So in terms of oral systemic treatment, methotrexate, as I said, is the most common first-line systemic treatment. Again, there's very few large studies to assess its efficacy, but it is well known as a very effective treatment for patients who have extensive disease that's very symptomatic, itchy. So I often offer this to patients who have failed multiple things or who are very symptomatic, and it works quite well. We use low dose, so typically ranging from 10, on average 10 to 25 milligrams, and it's a weekly medication. It can be taken orally or as a subcutaneous injection. So for patients who are not really responding to oral medication because of absorption issues, it can be injected subcutaneously or under the skin. You take it along with folic acid, and the way that it works is methotrexate inhibits an enzyme that's important for DNA synthesis. And ultimately, this affects how cells grow and prevents it from growing. It also suppresses the immune system and decreases inflammation. So methotrexate has been used for a very long time amongst dermatologists and rheumatologists for many inflammatory disorders. We use it for atopic dermatitis or eczema, psoriasis. In some of my patients with mycosis fungoides, I also offer or use methotrexate. There's really only one study showing relatively large study showing efficacy of methotrexate in lymphomatoid papulosis by von der Heide et al. And in this study, they had a small number of patients, but they showed that 87% of patients treated had long-term control. And most of these patients were on treatment for around 39 months. And in these patients, they had no disease for anywhere ranging from 24 to 227 months. So that's 227 months is a very long time. There are, of course, side effects with any medication that you take orally. So fatigue was very common, nausea, elevated liver function tests. And in patients who were taking methotrexate for a long period of time, they did report liver fibrosis in these patients. Bexarotene I don't often use, but it has been reported. There are very small studies, anecdotal studies, showing its efficacy. It's available as an oral or topical form, and it's a type of vitamin A derivative. It's a retinoid, and it binds with high affinity to the rexinoid receptor, retinoid X receptor, which is present in many organ systems in our body, which is the reason why it has very predictable side effects affecting the thyroid as well as increasing lipids. So we think it works by being involved in inflammation and regulating that, cellular differentiation and cell death. It is currently FDA approved for the treatment of mycosis fungoides. So again, in small studies, both the oral form and topical form has been found to be effective. So these are less commonly used treatments for patients who have recalcitrant lymphomatoid papulosis. So both the systemic or subcutaneous injection of interferon and intralesional injection has been reported in the use of lymphomatoid papulosis. Topical imiquimod, which is a TLR7 agonist, which helps stimulate the innate immune system and modulates the immune system in general, can also be used, but it has very local effects. So it doesn't affect the occurrence of lesions outside of the area that you treat. And then topical nitrogen mustard has also been reported. So there are only a couple clinical trials that I'm aware of that involve patients with really recalcitrant lymphomatoid papulosis. So brentuximab is a medication that is approved for the treatment of CD30 positive diseases, including ALCL and now mycosis fungoides, but it's a CD30 positive antibody. It binds CD30 CD30. So these are some of those clinical trials that are ongoing. So in summary, LYP is a recurrent and chronic skin condition characterized by CD30 positivity. And again, it's very important to seek out a dermatologist and have a pathologist who's familiar with the disease so that any diagnosis is not missed, because there are histological mimics and it really requires understanding the clinical presentation to make the appropriate diagnosis. Important is that the prognosis for lymphomatoid papulosis is excellent. And typically type B and C types of LYP tend to be associated with other lymphoproliferative disorders such as mycosis fungoides and ALCL. But interestingly, in patients who have both MF and LYP, the prognosis is thought to be better. And then, of course, treatment is determined by symptoms and extent of your disease. And observation is a reasonable option in patients who have typical lymphomatoid papulosis. So thank you very much for your attention. I'm happy to take any questions you might have.
Great, great. Well, that was really good. I always learn something new. It's wonderful. And I hope that everybody listening also had a chance to learn something they didn't know. And while we're waiting for some of the questions to get queued up, I actually had a couple of my own. You mentioned about, checking the lymph nodes as part of the exam. So would that just be a physical palpation of the lymph nodes, or would there be any other kind of lymph node exam required?
So for patients with cutaneous lymphoma, particularly lymphomatoid papulosis, it's basically a physical palpation. And what we look for are lymph nodes that feel typically greater than 1.5 centimeters. And some of the red flags that we look for when we perform a lymph node examination is whether and if the enlarged lymph node is fixed, if it's tender upon palpation, and again, also for size. So these are some of the things that we look for when we perform a lymph node examination. Of course, it can be very difficult to palpate lymph nodes depending on body habitus, as well as the location of where the lymph node is. But typically we feel the preauricular nodes, postauricular nodes, meaning in front of the ear, back of the ear, on the neck, under the neck, supraclavicular areas, under the arms, your groin, and those are kind of the more common areas that are assessed during the physical examination. And if there's any lymph nodes that are palpable and feel abnormal, and especially if patients have any associated systemic symptoms, then I will have a low threshold for scanning them, particularly if there's a concern for entities other than lymphomatoid papulosis. And again, I'll try to assess for and try to glean from the patient as to whether their lesions are waxing and waning, or if they're kind of persistent. So trying to distinguish between things like ALCL and other entities.
Right, right. That's always very good advice. So I had another question, few, because I've heard these things too. Oh, here we go. Here's one. I'll wait for my question. We'll answer this one. So far, 21 years on methotrexate. Heard that it has a rare side effect of destroying your lungs. How rare, and what signs should I be watching for?
Right. So that is a very, very rare disorder, a side effect of methotrexate. So it's an inflammation of the lungs that can sometimes happen with methotrexate. And, typically signs that you should look for are difficulty breathing. Again, I personally have never seen that in any of the patients that I've treated with methotrexate. It's, again, most of the side effects that you will encounter are all dose dependent. So depending on how high your dose is, you'll certainly see more of these side effects. But the side effect associated with lung is extremely rare.
Okay, great. And would that be, if some people, as that person said, they've been on methotrexate for 21 years, so that's a long time. Does that increase over the course of time, or do we know?
Yeah, that's a great question. I know that we always worry about liver, its effects on liver with regards to cumulative exposure of methotrexate. So with patients, particularly, most of our guidelines are kind of taken from patients who take methotrexate for psoriasis. And there has always been a guideline of assessing for liver function by liver biopsy in patients who are taking, depending on their associated liver disease, 1.5 or 3 grams cumulative of methotrexate. But that recommendation is becoming or will be not quite as important in the upcoming guidelines for psoriasis treatment. So certainly for liver toxicity, we worry about cumulative exposure and long-term exposure. With regards to lung disease, I imagine it's similar to that, but it's really hard to know because it's such a rare side effect. I would imagine that long-term exposure and long-term high dose exposure might increase your risk of that, but I don't know for sure.
Yeah. Again, just not enough data, right? And studies along those lines to be able to pull all that information together. So we've got more work to do. Okay, let's see. We got that question, Mike. We need the next one. Let's see. Give him a minute. But I also had another question. So I know I've talked to folks that have been diagnosed with, maybe I should go backwards. How would you diagnose someone that had both mycosis fungoides and LYP? Like how you have to take multiple biopsies and the clinical presentation. Is that the best approach?
So patients who have both mycosis fungoides and LyP, so they will present with the typical patches or classic patches of mycosis fungoides, and you'll see this on exam, or they'll biopsy can be helpful, but clinically you can certainly see this. So the biopsy for mycosis fungoides will be different compared to lymphomatoid papulosis if you biopsy a patch versus a papule of lymphomatoid papulosis. So that can certainly be helpful diagnostically, but clinically you'll also see this. So patients with patches are typically patients who have both LyP and MF. If patients have LyP solely, they really shouldn't have additional patches clinically.
Got it. And then, so sorry, I'm just going down this road because I have talked to people that have both. So would the treatments treat both at the same time, or would you have to do 2 different kinds of treatments?
So fortunately, a lot of the so patients with both LyP and mycosis fungoides, so their mycosis fungoides tends to be early stage. So fortunately, treatment for both LyP and early stage mycosis fungoides is both similar and effective. So topical steroids can be helpful as an adjunct, but phototherapy can be very helpful. Methotrexate can also be useful in patients with mycosis fungoides. And then certainly phototherapy. So a lot of these skin-directed treatments that we use for early stage mycosis fungoides can also be similarly effective for patients with LYP. So that's the good news. You don't have to undergo 2 different treatments. One thing that I try to keep in mind is that if patients have CD8 predominant disease, I try to be a little cautious about using things that would stimulate a CD8 positive neoplastic cell. So things like imiquimod, which would increase the Th1 or cytotoxic T cell, or potentially interferon. So I would use that very, very cautiously in patients who have CD8 positive disease.
Got it.
All right, Susan, I'm going to read some of the questions, if that's okay.
Okay, great. Feel free.
Okay, the next one is, my son was 3 when he was diagnosed 3 years ago, and he has been lesion-free in remission for 1.5 years now so far. Can this be a complete remission, or will it come back?
So that's, we don't typically see complete remission in patients with lymphomatoid papulosis. So it can potentially recur again. And that's why it's, and again, you can potentially have other secondary malignancies, but that's why it's important to continually watch the skin and to follow up with your dermatologist. But patients can have very, very prolonged remissions that can last several years, and it's very difficult. And a lot of my patients ask me, well, when will I have a recurrence? And it's very hard to predict that. And it's, I think, part of the really heartbreaking and hard thing about treating patients with mycosis fungoides or CTC or cutaneous lymphoma is that it does tend to recur, even though patients achieve a long remission. So it's very hard to predict.
Okay.
And very individual.
Yes, yeah.
All right, the next question. Getting my first shingle vaccine next month. Is this okay for patients with LYP?
Yes.
Question.
Yes, as long as you're not on any immunosuppressive medication, it should be fine.
Okay. Another one, I do get lesions from time to time. Some of these seem to fill up with a thick gel, and sometimes they fill up like a bubble. Why do some of these seem to need to fill up and some just dry up and go away? Is there a quickest way to dry these up?
So it sounds like there's a lot of inflammation in some of the spots that are, getting blistered so sometimes in very inflammatory disorders that have what we call interface, or just a lot of inflammation, sometimes you can get kind of a lot of this blister formation. But in terms of how to dry it up quickly, topical steroids can be very helpful, a cream version versus an ointment. The creams can be a little bit more drying, so that might be very helpful in your case.
Okay. My son, age 17, has LYP and has recently had some irregularities in his blood, urea, nitrogen, and creatinine levels. Has there been any connection between LYP and kidney issues?
No, none that I'm aware of or has been reported in the literature. I would, wonder if he's on any other medications or how high his creatinine is and how consistently elevated it is. And certainly follow up with the primary care doctor, because I don't know of any specific associations with kidney and LYP specifically.
Okay. Michael Young from the Cutaneous Lymphoma Foundation Board of Directors thanks you so much, and he says we love Doctors Rook and Kim and your whole team. So there's a shout out there. The next question, does the UVB light direct on the lesions or my body absorb the light and help from within?
Oh, good question.
That's a great question. So there are different modalities for phototherapy. So there's excimer light, which is very specific. So it's very focused in terms of delivery of the UV light. UVB tends to treat more superficially than compared to UVA, which goes a little bit deeper. So whether or not it treats you within, so interestingly, they've done studies to look at clones in the blood and compared that to the skin, and they have not necessarily been synchronous. So, I guess my answer is that it can help internally, but whether whether blood involvement is really significant in patients with lymphomatoid papulosis, I don't think we have evidence for that, if that answers your question.
Okay. All right, next question. Susan, just jump in with any comments. Otherwise, I'll just keep, as I'm not able to bring them up on screen. All right, 21 years ago, I was diagnosed with LyP between A and B. Can my body have developed different subtypes since then?
Oh yes, absolutely. We have evidence, and it's been reported that patients can have multiple subtypes of LyP at any one time. So that's definitely a possibility. Definitely a possibility.
All right. How does diet and alternative treatments affect LyP?
Always the question.
Yeah, yeah. I always get this question and amongst my patients, and I wish I had a good answer for that, because if we could do something differently with regards to what we eat or how we exercise or how we otherwise conduct our lives, I would love to give that information and that advice to patients. But we don't have convincing evidence for a lot of our medications that we do. We don't have large studies because the disease is so rare, and to conduct studies with alternative treatments and to then impart that advice to patients we just don't have that compelling evidence. So I personally don't counsel or advise my patients of specific diets or exercise or things like that, because we just don't have good evidence. And I feel like if you're restricting your diet, you're making your life more miserable, I think. So if we don't have good evidence, then why do it? But so I personally don't advise patients of different ways to eat or exercise. It can certainly be helpful ways to eat healthy and live healthy, but if it's a restrictive lifestyle, I don't know if it's necessarily going to make a huge difference.
Okay. Are there any trials with stem cell transplant for LyP patients?
Goodness.
No, not that I know of. There are studies using CAR T cells in patients who have non-Hodgkins lymphoma, but no studies with regard to stem cell transplantation. So
Okay.
I think a lot of it is because it's just. Go ahead.
As I say, it's a pretty aggressive
Treatment, right?
treatment or procedure to undertake.
I agree. And I think that one of I'm hoping that I was able to convey to patients is that LYP has an excellent prognosis. So I think it's very important to recognize that so that you don't feel compelled to overtreat the disease, because patients can live with it if it's not symptomatic. So making sure you're not overtreated is equally as important as getting treatment if you are symptomatic and have extensive disease.
Right. Right.
Okay, my husband has cutaneous B-cell lymphoma and only presented a lump under his arm, which was removed and had radiation. He has recently been diagnosed with primary liver cancer and is getting a workup for a liver transplant. After a transplant, being on the anti-rejection drugs that will suppress the immune system, what do you think of the likelihood of the lymphoma recurring and causing problems?
So we're talking about primary cutaneous B-cell lymphoma?
Yes, in this case.
That's also very, very difficult. Typically, patients with primary cutaneous B-cell lymphoma, whether that's marginal zone or follicular center type, they do well. As to whether immunosuppressive treatment will then cause recurrence, and from this description of this patient, it sounds like he has lymph node involvement. I would definitely proceed cautiously because we don't know the data for that. For other things that are that do similarly well, like pleomorphic CD4 positive pleomorphic small to medium T-cell lymphoproliferative disorder. There's some data showing that if you are on immunosuppressive treatment, it can potentially recur, and this is a less the prognosis of this disease is better. So it's really hard to know whether the immunosuppressive medication would cause recurrence. It sounds like this patient has more than just primary cutaneous B-cell lymphoma, so I would be very cautious.
And probably just make sure that all the clinicians that they're seeing are aware of everything that has gone on before, and make sure that they take that into account, right, when you're looking at options and treatments.
Right, absolutely.
Okay, I think we've got about 5 minutes more for questions. Looking at the next one. My mother passed away when I was 6 from Hodgkins. Having been diagnosed with LYP, does this increase the likelihood of getting Hodgkins?
So, the genetics associated with LYP and Hodgkins, you're potentially at increased risk for developing Hodgkins, but we really don't know. So.
Good questions. We just don't have enough data yet to really be able to understand what that predisposition may be. But just stay connected with your physician, I guess, is the best thing to do.
Okay. Here's the next one. I and my doctor agree with not over-treating this, but I've seen some doctors who felt I should treat this more aggressively to keep it from progressing further to malignancy. What are your thoughts?
I agree with not over-treating it. We don't really have data to show that treating LYP or even mycosis fungoides aggressively, particularly if it's early stage mycosis fungoides, whether and if aggressive treatment prevents progression of disease. The decision to treat is I think is based solely in terms of how you feel, because again, we just don't have enough data to show that if you treat with methotrexate or something else, that it won't progress or you won't develop mycosis fungoides or some other lymphoproliferative disorder. So I agree with not over treating in that case.
Okay, a few more. Has there been any studies with using CBD oil to treat LYP?
No, not that I know of. Yeah, I know CBD oil is used in a lot of different disorders, and I think some of my patients have used it. But I don't know of any data specifically of use of CBD oil and cutaneous lymphoma.
Okay, and we've got two left, Susan, and then I don't know if you still had one
All
in your
right.
back pocket, but what is the best treatment for scars left behind?
Oh, that's tough. So, you know, treating scars in general can be very tough. Usually I typically recommend good sun protection to prevent it from getting darker or more prominent. So sun protection and just a tincture of thyme, because thyme often is very helpful in terms of remodeling the collagen under your skin and improving the look of the scar. Certainly, if there are cosmetic procedures, and you can seek help through a cosmetic dermatologist who's trained in treating scars. But usually it takes at least a year for it to completely change and stop changing in terms of appearance. But sun protection is always helpful.
Okay, and one last question. What's the difference between type B and type F? Can one or do both resemble folliculotropic mycosis fungoides under the microscope? Is it folliculitis? Is folliculitis a common diagnosis?
So what types? Which ones?
Okay, it was the difference between type B as in boy and F as in Frank.
Oh, okay. Yeah, so sometimes type F can be very difficult to distinguish from follicular MF. There are features of folliculotropism, meaning it can involve the hair follicles in different types of LYP. But clinically, folliculitis, meaning inflammation of the hair follicle, is a common differential diagnosis when looking at patients. So I don't know if that answered the question.
Sounds like it's hard to tell, and good to go to someone who's seen a lot of cutaneous lymphomas and LYPs to be able to determine.
Yeah, and that second question was, can one or do both resemble folliculotropic mycosis fungoides under the microscope, and is folliculitis a common early diagnosis?
Oh, I see. So yeah, so again, folliculotropism can certainly be seen in some types of LYP. Type F can certainly have those features. Clinically, if you have folliculotropic mycosis fungoides, you'll have other clinical indicators like patches, plaques, and they don't, again, in contradistinction to the difference between LYP and MF is that in LYP, lesions will tend to resolve on their own. So you'll have spots that will appear and then go away. Whereas in MF, if particularly folliculotropic MF, that will never be the case. It will rarely be the case. So that's one of the most important ways to distinguish that. Folliculitis as a mimic, I suppose, because mycosis fungoides is a very the most common mimicker in dermatology. So really, it is important, as Susan said, to go to somebody who's familiar with the presentation of these diseases and who knows what to look for, where to biopsy, and what tests to run. So,
great. Well, all good questions as usual, and thank you so much for sticking with us through all the questions and answering everything so well, and hopefully everybody got their questions answered tonight. And I know you probably want to get back to your family and have a nice Friday evening, but thank you so much, Dr. Villasenor-Park, because I think having this conversation specifically to LYP was really helpful. And I'm sure as people watch the video after tonight, we'll also get a benefit from it. So we really appreciate your time and your answers to the questions and dealing with LYP. So thank you so much. And just a few other announcements. We have our last patient education program of the year coming up next Saturday, November the 2nd in Framingham, Massachusetts. So if you're in the area, we hope you'll join us. We have a really great slate of clinicians coming to speak, and we hope that you can join us next week. We will be having our November Facebook Live is already scheduled, and that's out on the website. It's an open Q&A with Dr. Sarah Knorr from Memorial Sloan Kettering. So we're very excited about that. And on December 11th, our Facebook Live, we're going to take a little different twist on the theme, and we'll be talking with a patient, Sheila Johnson, who is going to do some cooking for us. So we're going to talk about eating healthy and eating well and how do you cook? So we're going to have a good time doing that. And let's see, did I miss anything else? I think that's it. I'm sure there's something else I missed, but if you need any other information, please check out the website. We've got lots and lots of things that can help you answer those. And if you have any other questions, feel free to give us a call or drop us an email. And we really do thank all of our sponsors for helping us bring these programs to you every month. We couldn't do it without everyone's support. So thank our wonderful producer, Mike Grayab, who does such a great job behind the scenes. And I'll give a quick shout out to our program manager, Hillary Romke, who just came back to join us today from maternity leave. And we're so excited to have her back. So thank you, everybody. Have a great Friday evening and a great weekend. And we look forward to seeing you on our next Facebook Live or at one of our programs, or catching up with you on the phone or via email. So good night and happy Halloween, everyone. Take care. Bye-bye.